कुछ सवाल भी पूछेंगे तो आप उनका जवाब दे दीजिएगा। अगर कोई भी पॉइंट में आपको अनकंफर्टेबल लग रहा है तो आप हमें रोक दीजिए। Sir, I've taken the consent from the patient in her own language and have asked her that I've requested her to answer our questions, and if whenever she's uncomfortable, she can stop us. So my patient is post-operative day 16 of pylorus preserving pancreaticoduodenectomy, open Whipple procedure, which was done under general anesthesia. Patient is sitting comfortably. She is ambulatory. Her pulse is 82 per minute, beats per minute, regular. Blood pressure is 102 by 64 millimeters of mercury. She's breathing on room air, and her SpO2 is 98%. The tongue is moist, and there is on examination I had examined that she has anemia. She is afebrile. I would like to know her RBS, and she's not on any IV fluids.
Just to move it so that it can cover the thing. So that she's covered.
Folies is in situ. In the back, there is almost 300 ml of clear, light-colored urine. She is tolerating soft diet and she's passing flatus and stools daily. In the left drain, there is 200 ml of serous fluid present. It's a Romovac drain, which is not in negative suction. In the right side, there is 5 ml of serous fluid in the tubing. However, there is pus in the lower tubing, and this is also a Romovac drain, and it is not maintaining. It is not on negative suction. Her abdomen is soft. It is non-tender and non-distended, and the
Your patient is upright, sitting comfortably. Definitely a feature of a very good surgery and a very good recovery, because you would. This is POD
16.
16. So would you keep such these patients that long?
If there is no complications of past 3 days, she's been afebrile, I would discharge her. Only thing I would like to know is the amylase levels in her drain, and then I can surely discharge her.
So therefore, there are just subjects. So don't say we won't. The patient may be discharged earlier, may be discharged later. So it depends. So it's not always one way of dealing with it. So you said now that I would like to see the amylase level. So let's start from where you started. It is a POD 16 of a Whipple's procedure, pylorus preserving. What do you understand by this concept of pylorus preservation?
Sir, initially, based on the Billroth surgeries, they would do partial gastrectomies and then gastrojejunostomies. So there was dumping syndrome, and that is why, to prevent that, the concept has changed to pylorus preservation. So there is because of that, the dumpings.
Anybody who would like to add on?
There is a delayed gastric emptying. Earlier, it was thought because of the cutting of the lateral nerve in distal gastrectomies, and there is also, sir, bile reflux. To prevent those, the pylorus preserving duodenectomy, pancreatic duodenectomy was preferred initially, but this concept has now been taken down, and the Whipple's procedure is continuing.
No, after all, pylorus does have a function. So when they're preserving it, it was for a particular reason. And the only problem is it's a challenge in some situations to preserve it. Because after all, you need to make sure that you get a clear margin. So it is easier to not preserve it. Preserving it is a challenge. So when you're doing the preservation, you have some positive thing in your mind. That is, you will be definitely delay the dumping. And dumping is an issue. Why would we do the preservation pylorus?
So pylorus plays an important role in preventing dumping syndrome.
Also, the same thing you're saying. You mentioned something about the nerve of Leydig being cut. So, can you tell us about the course of vagus nerve in the abdomen? Does anyone have a paper to draw it on? Or these guys, you must be having your iPad? Draw it. Okay.
The junctions of fundus. So this is pylorus.
We can make out. Yeah, please show us the vagus.
So this is the anterior
anterior vagus, and at the posterior, we have two branches. So both the nerves. So in
If you don't know, it's okay. And you confusing, no problem. He was the one who was remembering Latarjet, so he is the one who has to do it. You have an iPad? I thought you were volunteering.
I'll draw.
Oh, yes, come. Wonderful.
This is the left anterior vagus. It gives the hepatic branch. Then it continues to give the gastric branches and the final nerve of Latarjet. This is the posterior vagus. It gives the criminal nerve of Grasse, the celiac branch, the gastric branches.
It's something similar to, you heard it before, there's some mistake there. You see, it enters into the abdomen and divides into left anterior and right posterior, kind of. Is it? And as it enters the anterior, when it gives, anterior gives off a hepatic branch, which is right. And the posterior gives off a branch to the celiac plexus or the solar plexus, because it looks like the sun rays, right? It continues down as anterior nerve of Latarjet. Ends up at a crowfoot here and gives off parietal branches. These are branches. That's why the term parietal cell vagotomy came into use. Highly selective vagotomy is also called as parietal cell vagotomy, because these are P cells, directly responsible for the production of vasc. Yes. And the criminal nerve of Gracie can either come from here to supply the fundus, or it can come from here. So that's why they found that if you do selective vagotomy, you may miss it. This can cause criminally it can cause the raised acid, so that is what the trouble was. Now, this gives off a branch to the pylorus, which is called the pyloric branch. So if you cut the truncle, this trunk, you're actually cutting off the pyloric supply also. That's why drainage procedures were mandatory. So you had no choice but to do pyloroplasty or gastrojejunostomy, because you already cut the nerve supply to the pylorus. Is that clear? Maybe they are not able to hear me. Are you able to hear me? You may not see, but you will hear that. This recording you will see anyway. And the posterior one gives off the branch to the celiac plexus, which is called solar plexus. And if you press that plexus, there is reflex bradycardia, what is called as Gold's reflex. So one of the kicks in in Kung Fu is hitting at the umbilicus. It's one of the anatomical sites of murder. Okay. The moment you hit here, there is bradycardia due to celiac plexus getting stimulated. Solar plexus, not solar, sunlight, right? And you block it to, relieve pain in situations that, pancreas-related pain, intractable pain, etc. Now, so this has nothing to do with the nerve of Latarjet getting cut. It's basically pylorus getting lost when you do a conventional Whipples, then you end up transecting here. So you have no choice in any case to drain. So that's why to preserve it would mean you're preserving the entire physiology. So you're preserving the pylorus along with its blood supply, nerve supply, and everything. So that would not suffer. Crowfoot is the end of it. And there's a prepyloric vein of Mayo, which divides the pylorus from prepyloric. That's where the pylorus starts. So from outside, if you have to see that vein is seen, when you're calling every ulcer, perforation from duodenal first part. Back to the case. This was a brief understanding. Give a broader paper to write next time, so you'll understand better. I hope that's clear. Yes. So that's about the vagus. So the dumping can be prevented. So you can do pylorus preservation, but it's technically demanding. And a good job done. That is what you should say. And gastrojejunostomy, what kind of a gastrojejunostomy they would be doing?
Preferably anticholic gastrojejunostomy.
Using a true loop?
Yes, sir.
Because in any case, there's only one loop left now, with which you'll do the hepaticojejunostomy, pancreaticojejunostomy, and gastrojejunostomy. Which one do you do first?
First is the pancreaticojejunostomy, followed by the hepaticojejunostomy, and then the
How
gastrojejunostomy.
much distance do you keep in between? Any
10.
guesses? Anybody? You can all chip in.
10 centimeters.
10 to 15 centimeters? Why do you need this gap?
So that the hepaticojejunostomy is tension free. And for
What is coming through this? What is coming through this? What is coming through this? You don't want the whole GB pokery happening. That acidic thing, bile, pancreas, you want to keep some distance. So therefore you keep it. And never mention jejunum in terms of centimeters. Mention in terms of the arcades. How many arcades is what you get? How many centimeters?
10 centimeters.
You're doing GG at least 20 centimeters.
For GG.
So 2 to 3 arcades. You can clear that. That's why I quickly know that. So now, do you think the patient is doing well? Why do you think the patient is in the ward still? When do you plan to remove the drains? These are many questions. So suppose this is POD1 and the patient is having difficulty in breathing. It's a scenario I'm giving to you. And you are the registrar on duty. How do you proceed? You can also answer from here also. You can take the camera to them. Anybody? Parametric.
Mobilize.
Patient has just been operated. It's just 1 day.
Oxygenation.
Okay. Anybody would like to chip in? Please feel free because it's a crowd. Yeah.
Sir, it's POD1, so my most likely diagnosis would be atelectasis of the lung and particularly the basis of the lung.
Simple. Keep it simple. Don't get complicated. Now I'll add it. Add more. What is atelectasis?
Collapse of the alveoli.
Yeah. So it's not maybe the basal. Why does the basal suffer? Limited diaphragmatic movements due to pain. So what do you do to make the pain, do the pain management in these patients? During surgery, after surgery? And what is PCA? What drugs do you use here?
Morphine and fentanyl.
Excellent. So, the answers come quickly in the house. Well, so you're going to be managing pain. And how do you ensure that pain management is optimum to prevent tachycardia from happening, respiratory rate settling down? How do you titrate the dose?
That's based on the patient's comfort. You have to ask the patient.
That's why I asked you, because then patient may take more than he should. And these drugs also cause respiratory depression. So you need to titrate it and be monitoring for at least 24 to 48 hours. So you need to make sure. How do you make a diagnosis of basal atelectasis?
X-ray,
Auscultation. Everything you will say clinical first. And then how do you do an X-ray of a supine patient to get the same result?
So head and
Head
elevation.
Some bit of head elevation. It's still a garbage X-ray. It doesn't show you much. X-rays are just shadows, and shadows are deceptive. So you may get a wrong answer. So what clinical examination can do, it may not do. So make sure you prop up the patient, oxygenate, chest physiotherapy, keep the environment warm and nice, and keep your attitude warm and nice. The cold attitude is worse than cold, which is what you observe these days. The residents are busy doing the checklist, which is not what training should be all about. Now, certainly somebody may question so many people in ward rounds, who doing those. It's learning, and that's the way it has been learned all these years, and people have done well. It's now only that we're making it worse. Nobody's comfortable. Checklist for you, checklist for the patient, checklist for the attendant. Everybody's checking list. It is useful, but you should monitor the checklist, and it will vary from one to the other place. Clear? So follow the WHO checklist. Having said that, what do you do for that atelectasis? So you're right. It's the first cause. I add something to it. And the patient is also looking at slightly cyanosed, a little blue. Trying to read your name. It's not just tachypnea. It's not just restless. It's also looking blue. Diagnosis, man. Don't waste time.
No.
No problem.
Saturation first.
Yes.
Situation.
Yes, he said the same thing. If two people have to say the same thing all the time, then one of them is not required.
My first this thing would be bleeding. If
Why should a bleeding person become blue and breathless?
the hypoxia, shock.
So, anybody here? Yes.
So, congestive, really.
What can you, what,
compromise?
ARD.
ACL-matic. Pulmonary insulin.
yes, common sense is extremely uncommon. Post long surgery, cancer patient, whether you, I was going to ask that question, what about the DVT prevention in these patients? What do you do before? What do you do during? What do you do later? Suspect embolism unless proven otherwise. Forget about this nonsense of saturation. Now you calculate everything else. How do you make a bedside diagnosis of it? You know or you don't?
Tachycardia
and hypertension.
So tachycardia more than 100 beats per minute. Then so there are points awarded. So 3 points to tachycardia and then 1.5 points to any prolonged immobilization, like 3 days
Let it
of
be louder.
immobilization. So 3 days immobilization or any
Surgery in the last 4
involving
weeks.
the pelvis or the lower limbs. Then sir, hemoptysis
Can
and
somebody record
malignancy.
the voice close to people? You can do the video, so
Sir,
you can have the voice matching anyway. Plan B.
Sir, 1 point
One more
for
person should be doing the recording.
sir, 1 point each for malignancy and hemoptysis, and 3 points each for tachycardia and any alternate diagnosis being ruled out.
All right, so any
Pulmonary
test you do to
embolism
confirm?
Sir, sir, in case based on the well score, if the score is low, then I would perform a D-dimer to rule out a risk of embolism, and if it is high, then I would have to perform a CT pulmonary angiography to look directly visualize the embolism.
Brilliant. You understand now? So it's not just vaguely answering, you need to be objective. He's given you an objective criteria. Can you repeat that criteria?
It's a modified well score. If the patient has a previous history of DVT or pulmonary embolism, we score it as 3. If the patient has tachycardia more than 100, then we give it 1.5. Hemoptysis 1.5. If there is no other alternative diagnosis, we again give it 3. If patient has a history of major surgery within 3 days and or has been bedridden for 4 weeks, then we give it a score of 1. And
What about malignancy?
some malignancies again 1, and if the score is less than 4, that pulmonary embolism is less likely. If it is more than 4, then it is more likely, and we go for a D
the
dimer.
scoring system to know it, and then you send for D dimers. And if you think it is present, what do you do? What's the immediate management?
So first is anti-fibrinolytics has to be administered, and if it is severe enough based on CT pulmonary angio, then the thrombus has to be evacuated.
Very clear.
So we can give recombinant thromboplastin activators. Then like step LT place, anti-NECT place. We commonly prefer LT place. So we can give LT place to the patient, and we should send the patient PT, IPTT, and INR over a period of 6 hourly, and then we can.
You got the question, you got the answer. So you need to manage it immediately. What would you find in the ECG, the changes?
First is sinus tachycardia, and then is S1, Q3, T3 in the third lead.
All right. So we make a diagnosis and you treat, correct? Suspect unless proven otherwise. You heard it? So don't just wish it away. Saturation, I'll check, then I'll call my senior, then they will call their seniors, and then they will call their seniors, and finally we'll prepare a file. That's not what you do. Management has to be instant. And for that, you need to know what you're doing. Now, coming to the case, I gave you one scenario, the second scenario now. It's 16th post-operative day, and the drain is still there. How would you know what it is draining? It's a clear fluid, as you can see. You described it also. So what is the first thing coming to your mind?
So it can be serous fluid or it can be pancreatic fluid.
16 days.
So then with this high output, I would go for a pancreatic fluid.
Now, suppose it is pancreatic fluid. How would you know it is pancreatic fluid? How do you make that diagnosis?
We'll send the brain levels of the, we'll send the fluid amylase level.
Will that be enough? Or is it the ratio?
Serum amylase, lipase we also send, and if it's 3 times the brain, 3 times the serum, then it confirm the.
What is it? What are the causes for false positive?
Amylase and lipase both are not very specific markers for pancreatic damage. So even in ulcers, cholecystitis, other abdominal pathologies, IBD and celiac.
They do rise, but here is a specific situation. The brain fluid has pancreatic lipase, and we measure the serum lipase. Then there's a ratio where we want to actually find out that this is not the usual secretion which is coming down, which may also have amylase. The leak can happen from hepatocytosis also. That may also have some amylase. And that is why it's important not to keep the anastomosis too close. How would you know hepatocytosis is not leaked? You. Okay, you carrying.
So biliary. The drain will have bile tinge and obviously
The bile is drained but it is leaked. How would you ensure that it is not leaked? You would say if it is not leaked, then it is not leaked. So, how would you ensure that HJ is fine, GJ is fine, PJ is fine? CT scan. How would CT scan tell you this is coming from pancreas, this is coming from liver, this is coming from somewhere else? So somebody here.
Patient might have biliary peritoneum.
Barium.
Barium study. What would barium show you?
Sir, if there are any leaks, we can appreciate on the submission.
No, sometimes simple things are not taught bedside. This is the bedside round. I actually personally don't believe in any exams because there should be no exams. People should be observed and should be declared, like it happens in the American board. The exam keeps your mind on something which is not important. How about putting in a nasogastric tube and aspirating? If bile is coming, HJ is fine. And what all you were talking? We'll hang the patient upside down, we'll do this, we'll do that. It'll also make sure that GJ is fine. PJ only God knows. The PJ you need to detect here. When the pancreatic jejunostomy leaks happen, what are the predisposing conditions? What can you do to prevent it?
Immunocompromised patient.
nutritionally compromised patient pre-op.
You see, there is one term which is so widely used is immunocompromised people. Everybody is immunocompromised when is having cancer. Do you know of any cancer patient who is immunocompetent? No. They're considering immunosuppressed individual constituents. Not nutritionally poor. Would you take up a patient for surgery if he's nutritionally not fit?
No, sir.
So we are talking about a case where you've done everything which is right in taking a decision about who should be undergoing surgery. So nutritionally the patient is fit, infection-wise the patient is fit, hydration-wise the patient is fit, coagulation-wise the patient is fit. We discussed here in the morning how to prepare a patient for Whipple surgery. Whatever you were presenting. So everything is good, but still it makes why?
Technique of anatomy.
Surgeon's
Well, it's one factor. The other factor.
Hypoalbuminemia.
I told you the patient is fit, man. So hypoalbuminemia is out. No? I answered in the morning if you were listening carefully.
Depth size less than 5 centimeter. Fine. Fragile pancreas.
Yes, and come forward.
Depth size is less than 5 centimeter, maybe we find the depth.
Okay. Anybody here? No, you answered it. I must take everybody.
If we check the vitals of the patient, if vitals are not deteriorating, then it means that nothing has leakage has not occurred.
No, that question was yesterday, sir. My question has moved. That was already answered. The question is, how do you anticipate it's going to leak? Now remember, for every question that you get in your life, forget about exam. Divide it into what is patient related, what is organ related, and what is technique related. So don't mix up. When you're answering for how do you make a diagnosis, how do you investigate, investigations to confirm the diagnosis, to support the diagnosis, to stage the disease, to treat the patient. When you're asked what can be your reasons for calling it cancer, points in history, points in examination, develop this habit. It's applicable everywhere. Besides allowing you a couple of more breaths before you actually die, it is also useful to make the examiner understand at least this fellow is organized. He may not know anything, but he's organized. So whenever he'll know anything, he'll put it in an organized way. You getting what I'm saying? If somebody is a good cook of South Indian dish and he makes it really nice, then even the British food he'll make good because his attitude towards cooking is good. And you can be passed for that. But at least he knows how to approach the concept of cooking. Getting my point? Therefore, organize yourself. So I'm organizing myself for you. Patient-related factors, well, most factors are okay. Obesity, you can't do anything to reduce the weight. Patient is on drugs, all the not on drugs now, suppressed on that account. All the cancers are on immunity. I don't use it widely. Stenting, I told you in the morning. Basically, stented for a long time, it leads to inflammation and fibrosis. And fibrosis, can anybody tell me? I think this is applicable to Tejas and you, Disha. Disha, you are right? To you both also. Why fibrosis after inflammation every time?
Macrophages leading to develop into the fibroblasts and one response.
Yes, Disha.
The inflammation promotes the proliferation of type 2 macrophages, which produce production of collagen.
Very good. Part A is done. 50% you got. But why? Question is why? Why should it be doing it? No, you sometimes should think. It happens that way, but why? Like you heard today, if you answered your why, you found your way. It's a very old quote I've used.
That is a point of constant irritation.
No, not that. Inflammation in general. That's why I brought it to you.
So that
Your
gas.
second year question.
Healing by scar.
Why?
Basically, the replacement of.
Why not replace it as it was? Why scar? Nobody likes scars.
So dead tissues and there is no stem cell.
Well, I'll answer that. Fibrous tissue is the cheapest tissue in the body that body can afford. It's cost effective for the body, but cheapest thing is usually not the best. And disorganized fibrosis leads to scar. Yeah. So any inflammation, whenever you have inflammation, fibrosis is the result because body knows only this. Now there are places where you don't want fibrosis. Can you tell me where? Your brain, your heart, your lungs. Brain, I'm sure. Agree, no? So brain, heart, lungs, bowel. So there are many situations like tubercular hydrocephalus. Steroids are given.
Reduce inflammation in their
Radiation-induced carditis, enteritis, dermatitis, whatever you call it, skin-related. You give steroids. When keloids form, you resect and you give steroids. Steroids are anti-inflammatory. Now, it makes no sense to give anti-inflammatory when you want inflammation. You want inflammation, but you don't want the last part of it. You want a good scar. Clear? Similarly, there are situations where you want fibrosis, but you don't want infection. You're talking about inflammation which follows infection. But I don't want infection. I want inflammation. They are aseptic inflammations. So inflammation is septic and aseptic. You can introduce inflammation by injecting some agents, like chemical agents, EDTA, cyanoacrylate. अब याद आते रहेंगे आपको phenol and 5% almond oil. That's a job you people do all the time. injecting the hemorrhoids, right? And making red thing white. So what is happening there? No infection. It's aseptic inflammation. Leads to fibrosis. And you want fibrosis. Why? Because it'll make the mucosa stick to the submucosa, no dead space, and vessels get fibrosed. You need it for sclerotherapy. And that sclerotherapy is nothing but fibrosis without infection. But here, the duct is getting infected and then there is fibrosis. So fibrous tissue is poor blood supply. Agreed?
Yes, sir.
And whichever anastomosis happens, wherever it happens, the single most important factor that causes failure is ischemia. And the most important factor that causes ischemia is tension. That's right. Why tension causes ischemia? Local fibrosis. Why was tension repairs? There was a time when hernias were repaired with as much of silk as possible so that there is more fibrosis because people believe there will be a thick wall behind. Then they realize this is useless because it's not pliable. It breaks. So now we use non-tension-free repairs. You put a mesh, which again produces aseptic whatever. In the presence of infection, we don't use it. Why? Is that clear?
Yes, sir.
So that this makes your technique. Anytime a patient lands up with a gastroenterologist with jaundice, first thing before they ask his name is they put in a stent. Now, with the stent in situ, you have a challenge to do anastomosis. It's likely to leak. Not enough evidence, but you know. And it becomes messy and fibrotic there to be set. If you have ever operated on this. He's right, we need an optimum diameter of the duct. What is the optimum diameter for anastomosis? Where is he? Wants it? Yes.
More than 5
5 to 6 mm. Less than 4 mm is critical. You can still do it by spatulating. How do you dilate the duct during surgery? You assisted in this case. You did?
Infant feeding tube.
Probe it. No, infant feeding tube won't dilate because you will get compressed. It's like you're using a balloon to dilate an area. It's different. So we have a spatula for that. Cheatling is the last option because the duct is still the same. In bowel, it can be done. Cheatling can be done. You do dilatation, and I've used the spatulas. You can use that one lacrimal probe,
Yes, sir.
So I use that. That's very good. The broader side. And when you don't have anything, take the tiniest mosquito forceps. Introduce the tip. It becomes broader as it goes. Don't try that first. Couple of times. Yeah. And then if the duct is very narrow, you do dunking. What is dunking? You dunk in like snake takes a frog in. Right? We don't see that happening in places now because there's no place for snakes to live now. There's hardly any space in Delhi. So we've seen when we were growing up, this could happen. And the snake is gradually taking, this is Duncan. So you have jejunum, you have the remaining pancreas here, and you keep taking sutures, rolling over and over, and finally it disappears. And you believe it is not going to leak, but it leaks. And if it does not leak, then either the jejunum or the pancreas, one of them is extremely lucky. And of course, the surgeon. But dunking got abandoned, but it's not a bad procedure when the duct is narrow. So what people do is duct to mucosa, a couple of bites, and then they dunk in also. They do it. Or they do pancreaticogastrostomy. They put it in the stomach. What can be the problem with that?
Not physiological. Acid and alkaline.
Very good. One, it's not physiological. And common sense says it is not going to work well, but it works well. The evidence says it's not too bad. But for some reason, you've taken off a lot of stomach. There is no acid. Very limited. That's an issue, I agree. Anybody? The outcome of pancreaticogastrostomy and pancreaticojejunostomy has been considered to be almost equal. It's just that the leak rates, obviously, pancreaticogastrostomy, if that leaks, then they say, no, it's not right. A fool with a tool is still a fool. You can do whatever. You can get a robot to help you, but eventually you need somebody to do it. Duct to mucosa is the best way to do it. Have you seen a duct to mucosa anastomosis? You've seen? You've seen?
No, sir.
No. Right. Ductal mucosa is what we do. And there are various techniques for this. Now, modified Bloom-Guard technique is what we practice. I think my video is there on YouTube. You can watch it. Watch the YouTube channel. It's free. I don't need it for me. You need it. So that's why it's been put there. There are many other procedures they're lying. Some are lying with him. We've not uploaded them. There's no time. We're busy. So it is like I can show it on some sponge or a paper how it is done. Basically, this is the stump of pancreas that is remaining. And the jejunum, we create a lateral opening. But we don't make an opening until we've seen the size of the duct. We have not yet cut it. So we have cut it and we got a feeding tube inside the pancreatic duct, which you must find. And therefore, don't use a diathermy to cut through or a harmonic to cut through. I take stay sutures and I try to cut piecemeal slowly so that I can identify the duct, isolate it, cut it, and a lot of people send it for frozen to make sure that there is no disease there. But you need to go further if there's disease. Now you got a duct. The only places where sutures will hold are the capsule of the pancreas and the duct. Nowhere else. So every other suture is a waste of time. Like in liver, doesn't. So what do? This is the pancreas. There is a duct in the center with a cannula in. I create an opening in the jejunum which is smaller than the opening here. Because I can always make it bigger. Never make a big opening to make it smaller later. It's small. Now what is lining inside? Mucosa. What is in between? Submucosa. Then muscle, of course. Serous. And what do I have here? An opening. Now this is, focus on this. I take a bite through the
Capsule with and duct.
You're following what I'm
Yes.
saying? And then next,
Duct.
I've not even looked at the duct. So I take a bite through. These are boxing sutures. Keep the, you've seen a sack of sugarcane or grasses that first need to be put together before you handle it further. Like I teach the K-stitch in tendon repair. If you watch my BSS courses. So we take a bite through and through. Capsule, 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 capsule. Then the second bite, so two kind of matrices both sides. They're not tied as a, they just stay. Clear? And then take a bite from the capsule. Duct. Clear? The cannula in there. And then the corner stitches, 3 are taken from the duct and mucosa, like you do for anything. This I've kept 1. Then outside in, inside out here, outside inside out, जैसे खींचा तो उसका खुल जाता है. And then we take the posterior bites. And when we are taking the anterior bite, we already have this buttressing suture on both sides. So as we close these towards the end, it kind of compresses the pancreas into a tube. This is a modified Bloom-Guard technique, which unless you watch me do it, you wouldn't understand. But understand, you should know the name. But it is duct to mucosa. Duct to mucosa. And we take 3 to 4 bites using 4 or 5 or proline or PDS. We use PDS. PDS is polydexon, which is delayed absorbable. And this tube has been cut already. The part of the tube goes in like a stent into the jejunum and we close it. Finally, this last suture which you heard, and then we take a layer of capsule, all in. Clear? Now there is a stent, which is a feeding tube between the duct and the jejunum. And you'll ask the question, what happens to this later on? Hey, just what can happen to this? Don't scare the hell out of when this starts.
So it can make obstructive.
No, we just pass it down.
Because of the peristaltic
One day you pass it. Which day you don't? It totally depends on you and the patient and the deal between them. And don't come in the morning like Junaid came the other day. You nikla aapka. Obviously, got to watch it. We pass it down very easily. no obstruction. That stent prevents that closure. Why do we need a stent?
No content goes and hinders the anastomosis.
Use one because there is post surgery inflammation and edema that can get blocked because of this. Sometimes it leaks simply because of that edema. Patency. To keep the patency, you put it there, and that's how a PJ is done. Then hepatocoagulopathy, interrupted or continuous. Duct is very dilated. Some people do continuous, but I do interrupted, and we take the same stay sutures in both the sides. Posterior layer first, anterior layer we take a lip up so that it doesn't. You don't take the two together, and then you close it. Don't stent it. Gastrojejunostomy is like gastrojejunostomy. And we put in a nasogastric tube beyond the stoma of the gastrojejunostomy. People have asked me, why do you put it? I don't know. It's a big enough stoma, and this stupid tube is not going to be a stent there. But it's been a habit. And what do? Second day, I tell them to pull it by 2 centimeters. So it is back in the stomach, and it starts draining bile. When it drains bile in the Ryle's tube, I'm happy. Why? HJ, GJ, both are fine. And I don't need any rocket science, no CT, sir, and no PG going inside and finding it out. Not required. It is easy. And then clinically, patient will have features of leak in the form of drain throwing, which may stop. When do you start octreotide in these patients? You know what is octreotide? Somatoside. When would you start?
When we find the pancreatic
I told you about the narrow duct. I told you about the stent, and he's right about the soft pancreas. When a pancreas is soft, it is safer to dunk it because it is likely to leak. Why is the pancreas soft? What does it indicate? What would a pancreas which is soft mean? It is a lot of auto digestion that has happened. So it's weak and it's not going to hold on. Dunk in. But dunk the damn thing in. Dunk, you know that? Slam dunk. You know about it? Basketball very help करता है. And inside the pouch. Well, so too tight. What do you do if there is a leak? Suppose it proves to be positive. The ratio is positive and the prevention. So now is the established leak.
Somatostatin inhibitor I will give. And if there is a collection in the abdomen, I would like to drain that as well.
So this is where you need imaging. And the best imaging is CT, of course. For collection, you need to guide your drain in the right place. Which all drains are used for draining pancreatic juice? What is a sump drain? Anybody can answer that? Sump drain? Not used very frequently, but I must. Yes, sir. Heard of it?
Some suction, I know, sir.
Yes, sir. Tell us about that.
There are multiple openings on all the aspects, so it's a tubular, so that at different levels it can drain and momentum doesn't get stuck in that.
But you've not seen it carefully. It is, you're right. You answered it. You should see some old churches, old buildings, which are again not there now. The skyscrapers. All the pigeonholes now where people live. So there's a pipe and there's a pipe outside. And the pipe outside has the holes. The inside is short, but it has a suction. So it will not get clogged. Because it is sucking. Suction is different. Otherwise, the solids, if you have a suction, just a drain, it will get blocked.
Yes.
But some drain never gets blocked. Why? There's a tube, another tube. The tube outside has holes. The inside is just for suction. So the inside is connected to suction, not this. Flow suction. So it drains. And this keeps on working. That will prevent what you were saying, the drain is not working. No suction is there. So that is what is required. You can't, of course, apply a lot of suction to a drain just like that. You'll get blocked. And all drains stop working when you need them the most. They cause infection, irritation, perforation. They are the cause of drainage. So you keep it because it is draining. And it's draining goes. You're keeping it, so you get into the chicken and egg nonsense. Then you don't know which one to go for. You will go for the chicken naturally. But that's the mistake. Drain is itself a cause of drainage and inflammation. You should know when to remove it. Don't keep it for beyond a point. Clear? In 48 to 72 hours, momentum comes and blocks it. Unless you use some drain. And you keep it in the lesser side. And then guided drainage can be done and treat by octreotide, which you give for 3 to 5 days. Some people give up to 7 days. They work only when it has happened. There's no role for prophylactic octreotides, except some people have used it in very soft pancreas where they suspect pancreatitis leaking, oozing, throwing. Clear? Any questions in this case? Now,
Sir, I have a question. Will there be any need of covering feeding jejunostomy in this patient?
very good question. I do it in all cases, not this case. Every case I do it. Why? Whenever in doubt, FJ. FJ. Because NJ is a gastroenterologist's invention, where they put a tube through the nose and they take it down to jejunum. It doesn't, the moment it gets blocked, you had it. I do feeding jejunostomy. I can close it whenever I want. It gets closed on its own. There's the GJ you can argue. But the feeding jejunostomy can be a lifesaver. Because all that is leaking out can be fed back into the feeding jet distally. What later on got a name, enteroclysis feeding. We were doing it in a lot of high output stomas and we published it. That is, you collect it and put it in the feeding jet. Either cynical, all duodenal injuries. You want collect to go, but do it immediately. If we observed some patients going drowsy we lost a patient also, Shagun would remember, because it stayed for a while, then the nitrogenous bacteria and all that stuff happens. It should be immediately used. And if it's in the intestine, then the contents are not the same that you can feed in. So be careful. You need to filter. It's a system of enteroclysis feeding, which you can do. So that feeding can help. But feeding jejunostomy is a lifesaver, a game changer. You must have feeding jejunostomy. People may not agree. They would say, you may do without it. They can. I like to. It's always your plan B. Whenever everything fails, your feeding goes on. Don't suffer. And remember, the best surgeon is a defensive surgeon. There's a quote outside the library. I hope they've not removed it from there. A good surgeon is not fearless. It's outside the Royal College thing. He fears for his patients, not for his reputation. He cares for his patient, not for his reputation. You should be defensive. So live to fight another day. And a living problem is better than a dead solution. Don't do a wonderful operation, but the patient doesn't live. And don't think like with due respect, a physician, this can be this can be that, this can be this, let's go to sleep. The differential is 7, 8 patient has died. And sometimes the death summary it's written, tuberculosis to be ruled out. He's already died. That should not happen. Take a decision. It may not be right or wrong. Take your decision, live with it, and die with it. That surgeon. Not the surgeons who keep thinking there's no issue. And whenever in doubt, go in. A negative laparotomy is better than a positive autopsy. And a living problem is always better than a dead solution. You can always go back, leave that option. Don't close an abdomen that is not closing. In the hope that it will open itself. If it doesn't like it, no. Before it opens itself, the compartment syndrome has happened. The physiology has already got deranged and don't think you're going to repair it. These are certain aspects you must look at. And deep vein thrombosis prevention is something which you should know in all cancer patients. So how do you do that? How do you ensure it?
So before the surgery, during the surgery, and after the surgery, 3 steps. Before the surgery, 6 hours, 12 hours before the patient should be given fragment of fixin and then stopped 8 hours prior. And then after the surgery, early ambulation is important. DVT pump is important. And we can start blood thinners again after 24 hours. And during the surgery, also DVT pump is extremely important. Reducing the duration of the surgery is also important, and well hydration of the patient is important.
Excellent. That's brilliant. And there is a checklist for that. DVT checklist should be filled. Can you look at the drain that is there, the color of it? When they put this here, okay. Now look at the color here.
This is not draining that much. That drain has 200 ml.
Go there. Let's see the other one. Excuse me. You can move to this side. Easier. Now this is the look of the drain. What impression do you make? All of you seeing?
This is darker than the normal.
It's not dark. It's not serious. This needs a test, and you would do when getting a marks. At 16th day, if this is serious, then it is ascitic fluid, which can happen post surgery. Oh, sorry. आप डिस्टर्ब तो नहीं हो रहे हमारे बातचीत करने से? हाँ, अगर हो रहे हैं तो बता दीजिए. Thank you so much. Thank you, Dee. Now, so if there is ascites thrown, it is post surgery, which happens. So what do you do to the ascitic fluid and drains?
So, ascitic fluid drains are sent for cytology to look upon if there is any.
Okay. Something more solid.
Sir, if the ascitic fluid quantity is more, we may need to drain to decompress so that the patient may not go into.
Correct the underlying cause and.
I wouldn't be asking for nothing. If it was that simple, why would I waste your evening here and mine too? Anything specific, madam?
So essay usually levels, SAB levels we calculate.
The important thing is what is she losing in that drain? Protein. So this you can't allow it to flow just out. So you should not allow free drainage. It's not a good idea. And replenish the albumin. So what is done? What do you do? Shagun, how do you make sure that the loss is covered? I won't be able to teach them. So you will give albumin and you will aspirate. There's a formula to calculate. You'll make sure that protein loss is not more than the patient has. Otherwise, this ascites is not going anywhere. The patient is never going to heal. It is the patient that heals, not the sutures, not the tissues. So important to supplement albumin and don't let it drain freely. You can even clamp it if it's not causing any discomfort, because that is a serious problem. And then intractable ascites needs to be managed by various methods. We're not talking about it. Peritoneal, venous shunts and all that. That's an intractable, long ascites. But this fluid looks to be the one that you need to test. How about she's taking orally?
Yes, so she's having she's tolerating orally well, no vomiting, and she's passing flatus and stool staging.
So this is a classical case where pancreatic fistula is there, 16 days long. Patient is constantly passing and it usually settles in a lot of patients. There's nothing wrong in keeping the drain out. Sometimes the drain would have formed a track, get the drain out, put a bag there, and the patient can live with it. But you need to make sure with imaging that there's no collection inside. Sepsis is a thing. And we should replace, I think they are doing it, and antibiotics should cover up for the anaerobes. And of course, should be broad spectrum coverage and monitoring should be adequate. Enteral nutrition prevents septicemia and it's therefore diagnostic very big. You can start feeding early. And enteral nutrition actually cures a lot of problems. Enterohepatic absorption of bile improves. Along with that, all the vitamins, IgA, immunity, electrolytes, fluid, immunity, and prevents villus atrophy. With villus atrophy not happening, the bacteria don't walk across the bowel wall. No transgut migration leading to gram-negative septicemia. So I always teach them, have guts, use them or lose them. Literally also. There's no point having them and not using them. They'll be atrophied. If you can't feed the patient adequately, at least keep pouring in some water. The peristalsis improves. If there is no peristalsis of the bowel, what can happen to the other organs? Tejas? Everything stops moving. So can you name something which, if it stops, will be disastrous? No, not heart. No, that will be a disaster. Adynamic obstruction of bile duct, cholestasis. Therefore, they develop jaundice. TPN patients develop jaundice. And then they have created a TPN with where you can give it to jaundice patients also, but you can't give more than a particular amount. But parenteral nutrition causes cholestasis. So much in one case, we move to the second. Have you taken a couple of
NJ version?
I think patients don't like a tube in their nose through going down. It is less invasive. So if I have to do just FJ, then I'll prefer NJ. But if I have to, I'm on the abdomen already, I would rather do an FJ. I'm being very clear. Ever since you handed over endoscopy to physicians, that's very simple to do.
There have been in cases wherein before closure of the patient, after the visit, we put an NJ intraoperatively, then we can confirm the position while maneuvering it through the.
You're not wrong in doing it. That's what I'm saying. I'm saying I prefer. I mean, there is a tube in your system. It may block. It may kink. It may get pulled up. It happens. I've seen it. And you had it. FJ is FJ. No patient is going to like a stoma. It's not pleasant. So NJ tube came as an advancement. Everything is not, you can't put a stent everywhere, like they put a stent for heavy obstruction. Does it work? After some time, the stent moves, stent gets blocked. There are issues with it. I'm not saying it is inferior, but not superior. The only superiority is if you were to put only NJ, then that's okay. I'm in the abdomen, I might as well do it directly there. Any other question? Can we take one more?
Yes, sir.
Tejas?
All of you move fast. We got to finish. A lot of things are covered.
कोई नहीं start. It's fine. They've been explained.
You लोग रहे तो दिक्कत नहीं है आपको. But I like the spirit. Get in. All of you. Although you want to hear, get in. You won't hear from Miles. You get in there. Get close in. He'll not be objecting to it. You can tell us.
A 69-year-old gentleman who is a resident of Borivali and who is a known diabetic and hypertensive.
Thank you, brother.
Is currently in his post-operative day of TURBT following recurrence of carcinoma urinary bladder with repeated TURBTs. The first one was performed in 2002 and subsequently he has received TURBTs in 2017, 2019, 2022 and even last year, 2024, due to recurrence of his symptoms of painless hematuria. And currently he's in his post-operative day 30. Intraoperatively, there was a rupture of the right anterolateral wall of the urinary bladder, which was repaired, and 2 pelvic drains were placed, which were the right-sided drain was removed on day 2, the left-sided drain was removed on day 11. And currently, he has a Foley's in situ, which shows 250 ml of high-colored, dark colored urine with no blood clots, and it is facing. The vitals of the patients are, his pulse rate is 88 beats per minute, which was measured in the right radial artery with a regular rate rhythm and volume.
Now he's otherwise stable.
So his blood pressure is on the higher side, 140/76 millimeters.
Otherwise, the surgery site is okay.
Yes.
And how much is it draining?
And currently only the Foley's is in situ, and the drains. So the left-sided drain, the dressing shows betadine stolon, and the right side has healed well, and the abdomen is soft.
So TURBT has been done. You heard of this procedure, no? It's done for what stage bladder cancers?
Non-muscle invasive.
No?
Non-muscle invasive.
Yeah, you heard that today. Because that is what you can approach from inside. Non-muscle invasive. If it's in situ and T1, what are the options?
So so like the bladder cancer, we first have a TA and T1. So TA is simply a growth within a papillary projection, which is not infiltrating the surface of the urothelium, but rather it is projecting inside the bladder lumen. So with a cystoscopy, we can diagnose the condition, and we can perform a TURBT, and the sample can be seen, inspected, and the histopathology.
Frozen and find out.
So any muscle invasion, lymphovascular invasion, perimental invasion, or any high-grade feature, it's required in histopathology. And in case those are present, we might proceed with radical cystectomy. In case those are absent, we can plan post-operative BCG or mitomycin, gemcitabine, some other agent to be administered through the Foley's, ensuring that the patient rotates in all directions so that all the walls receive the intravesical chemotherapy.
When do you go for the intravesical BCG?
So in T-A and T1 growths, which are non-muscle invasive and which have high risk. So
how does BCG work?
So it is an immunomodulator.
Yeah, so first time immunomodulator was used in this. And what is the contraindication treatment?
So in case the individual is immunocompromised.
Suspicion of tuberculosis anywhere else. If there is patient is diabetic, immunocompromised, you may develop tuberculosis. That is a risk. Barring that, what would be the presentation of a bladder in tuberculosis? That also produces
which is
bladder is pathology. That is pathological. So you lose what? Thimble is right. It's shrunken.
Yes.
And what happens to the ureter?
So it is king and
Called for the ureter. It is not cystoscopy. So you should describe these findings are on cystoscopy research. And now they've done, while they were doing TURBT in a recurrent case, they can continue doing it. It clearly indicates it's a low virulence, it's a low malignant potential that the tumor has got. So it's likely to do all right. Okay. Now, what would they have done? When would they think about radical cystectomy? You already told. So now, as of now, the anterior wall got damaged. So for your sake, I'll discuss that. More useful for you. So there was a drain put in the space of ZGS or the pre-recycle space, and there was a suprapubic cystostomy done, and there was a catheter entry. You do an SPC to make sure that it works. Otherwise, catheter alone is enough. Foley's is enough. So why do you put a drain there? You got a catheter in, you got a SPC.
In case of ruptured bladder, by the time spillage inside the pelvis, drain can pick up.
There is no peritoneum there. That's why I was saying. There is no peritoneum there to suck it out, and you need it bone dry to leave a drain there in the cave of HGS. Now, what do you remove first? The patient is fine, stable, going home. Drain first or SPC?
SPC first.
Good. And when do you remove the Foley's?
After 3 to 4 weeks.
So we will remove SPC first. Why?
The bladder will fill up and the
That sensation.
Think. It has nothing to do with the level at which you done a fantastic presentation of this case. I'm so happy.
So SPC, so we will first remove it because, sir, if there is any leak after the removal of the SPC, it can drain out.
Covering up for the same. So you want it to leak if at all. SPC is also a hole that you created, but almost seals the wall. It sticks to the wall if you do a proper SPC. But these days we are doing those endoscopic SPC, so there may be a space. So this is one question that can come to your use. You will be asked about the stages of bladder cancer. Same questions can be extrapolated here. Any pelvic surgery, any cancer surgery, any obese person for surgery, heparin, DPT, use of DVD prophylaxis is mandatory. they can, the moment they develop breathlessness immediately, post-operatively, along with their becoming cyanosed or developing a tachycardia and, arrhythmias, suspect embolism, do exactly as we discussed there, cover them up adequately with antibiotics. Now the histology will decide your better course of action.
So
Yes, yes,
the
yes.
histology report was inadequate and it showed that the specimen was taken from the muscle.
So we were not able to take it out, or maybe it was not there. Both options are there. They should retrieve their cystoscopy video and see where the tumor was. The recurrence was marked by hematuria, or the recurrence was suspected on hematuria. So hematuria may have.
So initially in 2002, when it began, so he had clots passing in the urine throughout the duration of urination, painless, and then after TURBT, it subsided for the first time for 15 years, and then when it recurred, there was milder hematuria, so only few drops, but since he was informed, so he sought immediate medical help, and the TURBT was repeated.
So now this repetition, the only thing we are discussing now is it is possible that there is no disease and eventually due to inflammation or something non-specific, or we have missed the lesion. Then we need to go in again to look for it. Any role of PET scan?
So it can detect distal metastasis and
Local also, but it's too early because you've just done surgery there. Got false positive.
So we can use blue light filters and
That you can do blue light filters. Yes, that can be done. We need to reestablish. Maybe at another site. We're just focusing on the site where the lesion was. It's a soil and seed theory in cancer. It's a soil which is like field cancerization in oral cavity, I told you. So here it's entire urothelium. Basically, the lining till the time it is the stratified, or the one that we talk about, which is common. The moment transitional, it is all, you never know where it is bleeding. So we need to exclude, we need to investigate further and to make sure that we find something. Or it was an inadequate job. That is also a possibility. In the event of the perforation happening, maybe they were not able to get it. And there is also a good chance for going in. In urology, vision is very good with endoscopy. So one won't recommend an open surgery also. You can't convert to this region. And this is not an indication for any radical surgery. Thank you. Let's take one more.
Yes. You are presenting? Okay.
I think we've got it closer.
So one each, sir. So she has also taken one. It's fine. She's been explained. She's been explained.
My patient Suresh, my patient 54-year female, case of choledochal lithiasis with right lateral abdominal hernia. Previously, a status post cholecystectomy. Patient had underwent CBD exploration, open CBD exploration, and on 7th of this month, and today is POD 17. And she patient is comfortable, conscious oriented, stable, and afebrile. She was tolerating soft diet and comfortably passing urine and stools. And patient was ambulating very well. And she is a known case of hypertensive. Otherwise, vitals are stable, not tachycardia.
She's stable in general. So what
Yes,
is
sir.
this? Is this?
There is a 20 French abdominal drain placed in the
This is the drain which is
Yes,
how many days post-op now?
POD 17, sir.
17.
Yes.
What is the drain draining?
There is a minimal quantity of purulent content in the drain, abdominal drain.
Okay.
And
Now she's afebrile. She's comfortable.
afebrile.
There's no T-tube in situ.
No T-tube.
There's a stent in situ.
Yes, sir.
CBD exploration was done and a stent was put in.
Yes.
It's open CBD exploration.
Yes, sir. Open CBD.
So what would the questions come to your mind? Why would a drain stay?
Sir, as per the patient's history, there was some pus discharge from the wound site. So probable case of surgical site infection and maybe
Is it
underlying.
inside the peritoneum or it's outside?
It is inside the subhepatic space.
So this is the hepatorenal pouch of Morrison, like you normally
Yes,
keep,
sir.
but it's stayed for too long.
Yes, sir.
So, where the local resident was, yeah? Okay, never mind. Let's not record it.
Okay.
So the drain has stayed for too long.
Yes.
You would like to get the drain out. It doesn't
Yes.
help. But after getting the ultrasound done,
Yes.
how do you look at this patient? What is there? What is the patient doing in the ward?
Sir, I would feel there might be a need for the drain as it is draining purulent content. And as I got to know about the MRCP which was done 5 days back, which showed collection in the Morrison region. So that is where the drain has been placed.
Does
and
it need repositioning if it is draining this little?
Yes, it may need a reposition
So
ultrasound
we do
guidance.
a imaging to reposition it. Now let's talk about open CBD exploration.
Yes, sir.
You saw the lab today.
Yes.
So how do you approach an open CBD exploration?
So in case of open CBD exploration, there will be a coccus incision similar to cholecystectomy. And after retracting the liver, we should, if the cholecystectomy is done, we should take hold of the proximal CBD and make an incision in the mid region as there is blood supply in 3 and 9 o'clock position. So after making an adequate incision, we may go for.
Now listen, I'll tell you, I agree with what you're saying.
Yes, sir.
First of all, understand that it is common bile duct.
Yes.
There can be an anomaly. The duct is dextral, artery is anterior, posterior portal vein is posterior. A, B, and P.
Yes.
Clear? Portal vein, P for posterior.
Posterior.
A, artery anterior.
Yes.
D, duct dextral, means to the right. Clear? Now, you would have done cholecystectomy first.
Yes.
You will know where the cystic duct is opening, so that job is done. You know you are at the CBD. Now, once you are at the CBD, you confirm that you're at the CBD by putting in a very fine needle,
Yes.
aspirating bile. You may laugh at it, but it's necessary. And then you take 2 stay sutures, man. You just don't put in an incision. Stay sutures at the 2 points that you mentioned.
Yes.
What are those?
3 and 9 o'clock.
So just
Adjacent
proximal,
Yes.
lift up. So that you also know this is a suture, which is keeping the blood supply okay. And you make a small nick in the center and suck out the bile. Don't let it spill over as you normally see. Not a good thing to have bile going places. Then you extend the incision upwards and downwards. How much upwards? How much downwards? So
it has to be small and then we increase as per the requirement.
good, small, and you may have to do choledochoduodenostomy in some cases. When you do that,
If there is a more proximal injury in the
no choledochoduodenostomy, what are the indications in general?
stricture in the CBD.
What is the minimum requirement of the diameter?
More than 1 centimeter.
More than 1 centimeter, ideally 12. The lumen should be 1 centimeter, 10 millimeter for the diameter, right? And you do choledochoduodenostomy, so if that is done in such a way that your incision, the lower limb is extended. Then you don't want to go up, correct?
Yes.
And you do choledochoduodenostomy by making an end to side. This is mobilize and go cockerize the duodenum whenever you have to explore the CBD. This is a mistake that most people do. Unless you mobilize it, you won't get a counter to hold. Which side is the surgeon standing when he's doing the CBD exploration? On the left side. Why? Because he wants his left hand to go behind the duodenum and right hand, the discharge and forceps to go in. It's not the other way around. If you stand here, you'll be struggling to go towards you. If the duct is going away, you cockerize a little bit only so that you can grip it and you know where the sphincter is. Be careful. And then you already done the cholecystectomy. You take the stay, make a smallish incision, drain out the bile. It is usually enough for putting a cholecystectomy forceps inside, up or below, and take out with counter. You can take out all the stones. And confirm that you've taken out all the stones by doing the perioperative cholangiogram, which was shown, or choledocoscope you can put inside, or you should know that you got now no stone by pushing in the. You would have done some investigation before also, as somebody was mentioning. Now, if I have to put a T-tube, I have this opening. I don't need to widen it at all. Why should I? The T-tube is trimmed and cut in a manner that its flanks are free. And we also cut it and keep the lower end shorter than the upper end. Why? Because the long lower end can go towards the pancreas and irritate it, cause pancreatitis. We don't need a very long one. And then to introduce it, you will flip it. One end is projecting, the other end is with the stem. You introduce it up, leave it, it opens up to occupy the lower part. And then only suture one side. Tube should be at one end, usually the lower end. And then start closing, interrupt it this way. So that it snugly fits. You don't put sutures on both the sides. Don't put it in the center. The chances when you pull it out can lead to leakage. Done? And then what you do, what we used to do in the past, we'll wrap it with Omentum, bring it out as close as possible so that the course is straight and Omentum allows it to form a tract, which is what you put it for. After 4 weeks, when the tract forms, you can go in to remove the remaining stones after doing T-tube cholangiogram, which will tell you if there is a stone or not. If there is a stone, then you will use choledocoscope or Dormia basket to remove the stone. If after T-tube cholangiogram, if there is nothing, you'll pull it out. There's nothing to be done. Coming to the choledochoduodenoscopy now. This is where we are. You make a horizontal cut here, which again is small. This cut is already there, which is vertical. Take a bite from here, take it out from this angle, hold. Here, this angle, hold. These are holding. So when you pull it, this becomes horizontal. And then you have two horizontal corners and pull the duodenum towards it, not the duct down. That's why cauterization was necessary. Don't do the other way around. Duct ko खींच के नीचे ला दें. Then आप ही नीचे आओगे फिर, duct नहीं आएगी. So you put the corners, the stays remain. In hepaticogenoscopy also the stays remain. There's the last to be tied. Then the posterior layer interrupted. Then the anterior layer over and over interrupted. And last this. Choledochoduodenoscopy done. T-tube is the easiest. No rule of no feeding tube, which we were discussing. Not to be done. T-tube is a tube like this and it has to be cut. But don't cut the radio-opaque end. The line is there. No? It's like somebody sitting on a tree and cutting the proximal side. But he's sitting on the same branch. No? That is what will happen. So if this is the radio-opaque line, I'll make sure that I keep this. So I'll cut it away. Flange. So that it's like pliable. It just needs to hold it there. It's basically a drain only. Choledochoduodenoscopy done. T-tube did. Management of T-tube is wait for it, the content to reduce, the jaundice will reduce because the normal passage should work. If it starts reducing over a period of 48 to 72 hours, if it gets down to less than 25-30 ml, you can do a T-tube cholangiogram earlier also. But you clamp the tube before that. Patient has no pain abdomen, no cholangitis, no fever, you can pull this tube out. But if the cholangiogram shows stone, and stones are differentiated from air bubbles by keeping it saline, filled, or by tilting the patient with ultrasound, the stone will come down, air will go up. So you can make out. And if there is a stone, then you leave this for 6 weeks. This tube will form a tract like any drain. Those drains have all formed some bloody tract. Get that drain damn thing out, put a bag there, it will work. Now, drain is the cause of this pus. And that cavity also is collecting it very nicely. So you keep on draining. Nature is playing trick. Patient is eating, no fever. What the hell is the drain doing?
Yes.
So you should be. And read my 2 randomized control trials, one in breast, the other in thyroid. The drains are not recommended as a routine. So this is done. This is what this case is. Any questions here? You should know this about.
Yes.
Choledochoduodenoscopy, when to do it. How would you make sure, how would you know, hello, how would you know that there is also a procedure called sphincteroplasty, which these days surgeons don't do. Everything is done by gastroenterologists now. The jokers never did anything fast. Given them everything. Or sphincterotomy.
Yes.
Not recording it so far.
She connected on.
All right, it's okay. You can watch it. Now, sphincteroplasty and sphincterotomy. I'm sorry, that's the space we have. Again, when you make a cut in the sphincter, make sure of the blood supply. So make a cut between 9 and 3. You make a cut and then open it up. It will open up like a V. Suture the mucosa to each side. This is sphincteroplasty. If you only cut it, it's sphincterotomy. That is also covered. Now, what was I telling you? If you've done sphincteroplasty, you know how they used to check earlier that your sphincteroplasty is successful. How can you check it? It was called that time Coca-Cola test. They'll make patient drink a lot of Coca-Cola and then they'll take an X-ray because the bubbles, gas will go up. So if there is pneumobilia with the air in the system, well done. Now, and I would say that the duck is enjoying the Coca-Cola, right? So we can do it with soda as well. I'm not insisting on Coca-Cola as a brand. Anything that is aerated will produce some bubbles. That's nonsense. You just do an X-ray. After choledochoduodenoscopy also, you'll find gas in the... so that indicates that your surgery is okay. Very useful. What is the problem with choledochoduodenoscopy? Where did it go? Yeah, what can be the problem? There is some disease problem called sump syndrome. You heard of sump just now. There is also a sump syndrome. What is sump syndrome? The duct is longer than where we did the anastomosis, no? So the gravels and the kachra keeps collecting here. And it is blocked. Ye drainage ho gaya idhar, but the solid things will keep dropping down. In the duct itself, because you not cut off the duct. So that gets infected or sump syndrome. In multi-stories, they can have this issue, the basement and the sump area. So that is called sump syndrome. I taught you about sump drain. Okay, I'll show you here. I need a bigger board. Now. That's why I'm able to show you. They gave me some shading.
How does it treat sump syndrome?
Sump syndrome is treated by regular washing or endoscopic opening. Sphincteroplasty, you open it, the kachra goes in. Because you bypassed it. Choledochoduodenoscopy is a bypass of obstruction. Some drain. There's the outer tube, there's the inner tube. Okay. And you attach suction to it. This has the eyes. So it keeps sucking and it works this way. This is connected to suction, so this has got no suction. The tube is inside the tube. There's a video of this in YouTube, my own video, somebody put it. So momentum will block it here, but there's some fluids will keep on going. You just put a normal drain, it may get blocked. So that is sump. Right, we keep something for tomorrow. Anything else?
One case. One more case.
Would you do for degeneracy also after mobilizing the jejunum, the similar techniques will be followed?
I showed you the technique. That is it. Choledocho. Get closer. Choledochoduodenoscopy. Okay. Now, this is the duct. This is duodenum usually. Now I'm bringing a jejunum up. It is much easier. I don't need to mobilize anything, right? So what do? This is a jejunum. I just can bring a loop or I can bring the entire loop. Make an opening here. It's always longitudinal. Horizontal here. Put the stay at the corners. This becomes touchless.
So which one to
we are talking about a different entity. Choledochoduodenoscopy is when you are, if you're dealing with duodenum, there's stones, multiple stones in the common bile duct, then we do this. Hepaticojejunostomy has different indications. It is done in Whipple's you are doing. Hepaticojejunostomy is done in a bypass also. Triple bypass?
Yes.
What are the components? Hepaticojejunostomy,
gastrojejunostomy and jejunojejunostomy.
So this is stomach. This is DJ. This is pancreas. This is a duct going in. All blocked here. This is all resected. And this is all diseased. So we can't resect it. So mostly we'll stent it. But the problem is later on they may develop gastric outlet obstruction also. So hepaticojejunostomy, making a roux loop or taking the loop up. And then gastrojejunostomy and jejunojejunostomy so that the contents don't go back into the common duct. The three, that is triple. It is only done if you are on table and you think patient is going to live for more than 6 to 7 months to get that obstruction. Outlet obstruction may not be there to begin with, no? And the patient doesn't live that long, then surgery is not really indicated. You can stent and forget about it. So gastrojejunostomy is done in anticipation. It may not be there. If it is there, then you have to do it. All right. So we'll catch up tomorrow. Is there another case?
One more case.
Who is taking it? Oh my God. Oh. Quick. डिस्टर्ब नहीं करेंगे
Consultation.
I'm presenting the case of Mrs. Kamlesh.
डिस्टर्बेंस नहीं हो रहा आपको? Sure.
Don't take name.
Please chip in here and close it so that we cover it up for the patient.
I'm presenting the case of a 58-year-old lady. She is a known hypertensive and is a post-operative day 8 case of a left modified radical mastectomy done under general anesthesia for invasive ductal carcinoma of the left breast following 8 cycles of neoadjuvant chemotherapy, which started in April of last year. On examination, the patient's vitals are stable.
So it's the 8th post-operative day?
Yes, sir.
Is the drain still there?
Yes, sir.
What is it draining?
So it is draining serosanguinous discharge.
How much?
It's a 50 ml since morning.
So it is really draining. And the patient can go home with the drain. We don't keep them with the drain. And usually, how do you make sure that, how do you reduce the drainage in breast? Post mastectomy, how can you reduce the seroma rates, drainage?
So compression at the site of incision.
So by washing by NS before closing the wound to get
That
rid
is
of the
always. Anything different? Enclosure? Well, so there is no one way of doing it. Correct? And there are many trials which show that no technique works, but there are various ways to reduce seroma rates in mastectomy. Ranging from good technique, meticulous dissection, not using diathermy that people felt was effective, but we don't know that it works. Using sealants, when you use sealants, ligating lymphatics, many trials, many things have been done. So that is technique related. Then the other is, you can do what is called as quilting. Quilting is where you fix the
superior flap with the underlying pectoralis muscle
in layers to fill the dead space. Third is internal as well as external axillary padding that people used to do. It is very harmful. It is very restrictive to the patient. Many people did not use it. And we did a randomized control trial and published in 2006 that if you use half suction, not too much of suction, the seroma rates drop. And many people did follow it up. You know, it's got an ISRCT number. Do some reading, you'll find an article where we found that half suction was more effective than full suction. So half suction reduced the seroma rates in those cases. And we found it dropped by 50%. We started sending patients with the drains home, teaching them how to manage their suction. And like I said before, full suction we found theoretically was persistent negative pressure to not letting the lymphatics stop block. The negative causes the lymphatics are still open. The second cause is seroma. Seroma is not a complication, it's chiefly. The tissues are weeping. Cavity is weeping. Serous fluid. But it's not complication. But if it gets infected, it will be complication. How does it get infected? Drain. So at some point you need to apply the padding and do repeated aspirations and discharge the patient. There's no point keeping the drains for too long. People have tried cyanoacrylate locally. People have tried internal axillary padding, which is suturing the pectoralis major with the latissimus dorsi to block the axillary space. That is internal padding. External padding is what you have seen, putting a pad in the axilla and strapping the hell out of the patient. And it stays closed that way. It doesn't work as effectively. It restricts the shoulder movements. There are studies to show that if you do more active movements of the shoulder, the seroma rates drop. So nobody knows. It depends on obesity. Technique of dissection is one factor only, not everything. But I think drain for too long in itself will cause. They will not be able to get the drain out because it will never stop. I gave you the example of chicken neck. That's what happens. So keeping drains for a long time is not a great idea. It will continue to throw because it is irritating and it's inflammatory and they keep on trying. Anything else you want to tell us? She received neoadjuvant chemotherapy. What drugs? How many cycles?
So 8 cycles she received. The drugs, they did not know which drugs she was on.
Why did she get neoadjuvant chemotherapy?
So she had hormone receptor positive.
Which is good news or bad news?
So it's good news.
So what good news? Why should they get neoadjuvant chemotherapy? So a situation could be it's too large, possibly not resectable, and maybe hormone receptor positive, but Ki67 is high.
Yes.
Or the HER2 was positive. Then they may be taking trastuzumab. We need to look into those details. And neoadjuvant chemotherapy itself is a cause for a lot of seroma because dissection is slightly different. Anything else you want to tell us about her now? She's already taking orally. She's received chemo. Can you start with something straight away? She's hormone receptor positive.
So selective estrogen receptor
Absolutely serves. So what are those selective estrogen modulators?
So tamoxifen, raloxifene.
Which of these you will prefer?
Raloxifene.
Why?
Raloxifene. Prevents endometrial hyperplasia.
Uterus is intact. But the ovaries are not functioning. So what is it going to modulate? So in postmenopausal women, you go for aromatase inhibitors. And what does aromatase enzyme do?
So it converts testosterone to estrogen.
One and peripheral fat release.
Peripheral.
So it will be more effective rather than tamoxifen in this age. Correct? And it can start anytime. But why can't we start straight away? What is the side effect of aromatase? Don't know, no problem.
Osteoporosis.
So you need to check the bone mineral density. And they are, as it is osteoporotic at this age, they develop pathological fractures, complications related to bone. Let's not starve the bones. We can put the patient on aromatase inhibitors after checking for BMD. Let her recover and get this tube out. It's not going to do any good. 25 to 30 ml in 24 hours is fine. Okay. Surgery done, 16 post-operative day. I'm asking you, and patient starts complaining, backache, body ache in general. What would you suspect? Rule out metastasis. Maybe the workup was done some time ago. You should start looking for it. What else will chemotherapy do to her, which you should take care of now? Cardiac toxicity. So you need to take care of the heart, so protect it with, so, and anthracycline and trastuzumab both. In these days, they use dual agents, trastuzumab and corticosteroid. They need to take care of that. Same question will apply here for DVT. Post chemotherapy, cardiac status. How do you take care? What are the drugs that produce cardiotoxicity? Chemotherapeutic drugs. You want to answer? You can answer. Dr. Rizin. Trastuzumab. That is. And you know, when earlier days we were using CMF, cyclophosphamide methotrexate, and the cyclophosphamide itself, I mean, adriamycin was cardiotoxic, but cyclophosphamide potentiated that. Okay, so radiation is what she's going for. You need to be careful. It's left-sided carcinoma. So how are you going to give a heart-sparing radiation? There is a DBRT, that is deep breathing, radiation therapy, which is given in a particular phase when the heart is away. Radiation shot, heart back, radiation shot. It's got image guided and very focused radiation that you can offer. One more complication of aromatase inhibitor is it's not very specific. It's the damage the liver or other things. You look for that also. You counsel the patient, you lost hair, bone marrow must be normally maintained, and you should supplement Shalcal and bisphosphonates. How often do you give bisphosphonates?
Weekly.
6 weeks or 1 weekly.
1 week.
There are all types of doses available. How much is 1 weekly dose?
So 35 milligrams weekly of Solendronate.
You
The ibadronate once monthly.
injectable or tablet?
Injectable.
This is the difference. She's going to be. Don't ask me, how do I come tomorrow morning? Because I'll have to also see the reach. If your learning depends entirely on your appetite, and that is your hunger. If you don't have hunger, you can go and sleep. Life is about sleeping nicely. You want to learn, you have to beat all that. Okay? And tiredness is a state of mind. You're born tired of it. You want to sleep. You came out in the world to be awake and alert, learning. So, if you're hungry, you learn. We don't advertise too much. Scrubs, we've been doing this so many years. I started Scorpion. And people came in. 700 people, no place to make them sit in RM and auditorium. I then decided group teaching is better. Talk, explain. Therefore, I'm not saying it for my sake. If you want to register for academic workshop, don't waste time because later on you will be there. It is space is filled. First come first.
We started getting entries already.
No registration, no seniority there. I don't care a damn. She comes before others, she stands before no faculty members. Learners, front. And the same thing can be taught to all. So make sure you initiate it. Any question from today? You ask me how? You ask.
Sir, after the minor surgeries, there are higher rates of liver.
Take a bigger pad. Yeah, he's carrying on. You
Higher
understand?
rates of pleural hernia observed after minor hernia surgeries. Sir, I was wondering why exactly.
You read something?
Sir,
Maybe the same people get bored. We do nothing to the femoral ring to get this. It's more common in women. But hernia per se, most common is inguinal hernia in women also. So don't get confused. Right? And what I was referring to was some kind of this is the arching fiber. They were unnecessarily suturing the two. It's got nothing to do with your hernia. Pubic tubercle, arching fibers. And you have the cord going in. So the weak spots are where the, the space is. Here you have muscle, but here you have nothing. This is inguinal ligaments. So that's why they're covering it. So they thought we'll block it. But that's like Zabardasti putting two things together. They don't work. Unless it's very lax. So then they thought about a bigger thing, the whole orifice. What is happening below the inguinal ligament? The femoral vessels are going. And that's a femoral ring here. So this they want to close, no, the femoral ring. And through this hernia happens. And very rare because you need a very wide pelvis to make it wide and upwards accumulate. But it can happen. So they think of blocking a bigger mesh. From behind only it can be done, from front it cannot be done. So all other hernias are suprainguinal block, taking care of suprainguinal thing. This takes care of this also. There was a hernia system, protein hernia system that came into use earlier, which was kind of flat. The first in North India I did. They forced me to do it. Because they wanted to publicize it. This goes in and this stays up. So you take care of both. Protein hernia system, go and watch. It was, I think, 98 or 90. So that took care of the posterior side. They were aware of it. Put one behind one. So this goes behind the fascia. And there's a connector in between. But they both hold each other in place. And you take care of the posterior, the femoral ring problem. Otherwise, femoral ring is just an opening. We put two stitches between lacunar ligament and the fibers here, and it gets closed. It's a very small thing. So there's no, I don't know of any evidence because you never know if any of it. So maybe they both have the same predisposition because it's after all a groin. Okay. Any of them?
Excuse me, sir.
Anisotropy sometimes in dimensions it stretches differently and
That is what the quality of mesh is all about. No, they pay for it. Stretchable meshes versus non-stretchable ones. Lightweight versus heavyweight. What do? You have 10 people doing the job and have a system that you don't want all 10. There's no space for 10. So have 5 of those who disappear. So all 10 are working. After some time when the work is done, 5 disappear. The space is adequate. Here we have composite meshes which are together with vehicle and proline support, absorbable or non-absorbable. After some time, the vehicle is absorbed, so the holes become bigger. So histiocytes are like pillars. The pillars coming. The pillars are occupying space, so you have a better wall, a roof taken care of. I've told you the concept of it. The rest you can build up, even you can make a mesh. It's not difficult. Any?
So I was very intrigued when you said hydrocortisone is the antidote for xylem.
So was I when I heard it first time. I read about it. So basically, it takes care of the mechanism of action of xylocaine. How does it work? Why is it cardiotoxic? Neurotoxic, especially because it causes hallucinations, delusions, and other things. There is some bit, nystagmus. It works at the neurons.
Sodium channel.
Sodium channel. There you are. So all this activity is put to standstill by steroids. And the best steroids in your theater are adaline. You don't have it, adaline is the best steroid you have. Hydrocortisone is easier to give. Adaline has side effects, cardiac effects. Beyond this, the cardiac effects get taken care of. But importantly, if you're using adaline, you should use lower dose. But then it stays more for local package. But it gets into system, everything is absorbed. It is not going to disappear. Then your adaline can produce advantage. So some people feel, what I was saying was the dose should be less. But the adaline itself is protective and you don't develop those effects. But it's contraindicated in elderly. Adaline you don't use just like that. So adaline reduces the dose of xylocaine that you need. Because it will be locally concentrated, the prescription. And creates a false bloodless field, which is a problem. Because you don't see them oozing now, they ooze later. And then hematomas form. So you should be very careful. Don't use diathermy when you're using adaline, because you will be causing damage. Vasoconstriction already happened, flap would necrose. So cold knife goes on. Okay. Thank you.
Thank you, sir.